So for chapter 27, we're going to be talking about anticoagulants, antiplatelets, and thrombolytics. And this is all to do with preventing clots, treating clots, etc. And we're going to talk first about coagulation, which is the process of the, usually in any normal process, let's say somebody had a cut, coagulation would be the process where a blood clot is formed and that bleeding is stopped. The wound would scab over and heal. That would be the coagulation process. In any usual circumstance, we want that to happen. However, in people who have those buildup of fatty plaques, we don't want that to happen. We want to keep the blood moving. We don't want to have the fatty plaques develop blood clots on top of them because the body recognizes them as foreign and tries to heal it. So coagulation is a four-stage process. Stage one, a substance known as thromboplastin is produced. It's produced by two different mechanisms, intrinsic and extrinsic mechanisms, and it requires many clotting factors to stimulate the production of thromboplastin. That's intrinsic, many clotting factors are used. Extrinsic just requires factor VII and tissue extract, a substance that is released from injured cells. Regardless of the pathway involved, once thromboplastin is induced, clotting proceeds automatically. Stage two, thromboplastin converts prothrombins to thrombin. In stage three, thrombin converts fibrinogen to fibrin and activates several clotting factors, 5, 8, 13, and protein C. Fibrin is the primary element of a blood clot. It's exactly what it sounds like. It's kind of the mesh that holds the platelets together. And the factors necessary for the clot formation require calcium ions to function efficiently. Vitamin K is also required for the synthesis of many of these factors in the pathway, and that's how one of the anticoagulants works, is by vitamin K inhibition. The clot is usually dissolved once its function has ended, and that is where thrombolytics will come into play. Stage four, plasmin is formed from the conversion of plasminogen by tissue plasminogen activator, or TPA, and plasmin is an enzyme that acts upon the fibrin elements to produce a more soluble product. Basically, it breaks it up. So as you can see on slide 6, there's the extrinsic and intrinsic pathways of clotting. Platelets and clotting factors are responsible for initiating coagulation. When an injury occurs, platelets or thrombocytes immediately migrate to the damaged area. Because platelets stick to each other, which is called aggregation, and through the vessel walls, which is called adhesion, they form a plug around the injured tissue. Plasma clotting factors reach the platelet plug and interact with each other to form a stable blood clot. Hemostasis is the balance between clot formation and clot breakdown that occurs throughout the day. So drugs that affect the coagulation pathway are really going to be our mode of attack to prevent coagulation from happening. So this includes anticoagulants, antiplatelets, and thrombolytics, and they can be given prophylactically or in the middle of, as treatment in the middle of an attack. So the clinically useful anticoagulants produce their pharmacological response by interfering with plasma clotting factors, inhibiting platelet aggregation, or dissolving clots. So that's three mechanisms of action. Inline plasma clotting factors, if they're interfering with those, it's anticoagulants. Inhibiting platelet aggregation, antiplatelet. Dissolving clots are thrombolytics. The mechanism of action determines the onset and duration of action, how long it'll act. For example, heparin has a quick onset and duration of action because the anticoagulant effect occurs as soon as the thromboplastin drug complex is formed. Warfarin has a longer action because it takes time to clear the clotting factors before an effect can be observed. Antiplatelet drugs that inhibit platelet aggregation so that the plug doesn't form, or so that they block platelet adhesion, these make the platelets less sticky, and their onset really varies. It's usually pretty quick, not as long as warfarin. It doesn't take that long to act. Thrombolytics are almost instantaneous. They start working right away. So, moving on to the heparins we're going to talk about first, and these are anticoagulants that are usually given subcutaneously or intravenously. There are standard heparins and low molecular weight heparins. Heparin is a naturally occurring mucopolysaccharide, first identified in 1928. Usually it was, the source was from the lungs and intestines of cattle and pigs. Low molecular weight heparins are derived from porcine, which is pig heparin, but only contain an active anticoagulant fraction of heparin. This accounts for their smaller, lower molecular weight, and they're not interchangeable with heparin. You can't substitute one out for the other. Heparins, including low molecular weight heparins, are considered peripherally acting anticoagulants because of their action with circulating clotting factors. As long as heparin is in contact with the clotting factors, coagulation is depressed and clot formation is inhibited. All heparins bind antithrombin and increase the speed of its inactivation of factor 10. Low molecular weight heparins are more effective at binding active factor 10, but standard heparin is more effective at inactivating factor 13 and binding thrombin, which is active factor 2. Try not to pay too much attention to that. Just remember that heparin and low molecular weight heparins are anticoagulants that interfere with the coagulation pathway. So the major toxicity with these medications, it is an extension of their action, and it's usually hemorrhage or bleeding. At high doses, it can cause bruises to form in the skin, which is basically just a collection of blood underneath the skin. It can also cause bleeding from open wounds, which fancy term for that would be exsanguination. So other side effects include fever, alopecia, osteoporosis, and thrombocytopenia. And remember, platelets are called thrombocytes. So if we have thrombocytopenia, it means we have a reduced platelet count. There is an antidote for heparin, and it's called protamine sulfate. And we can give that in a certain ratio to the amount of heparin that was given in order to reverse the effects. We never give these medications when the patient has an indwelling epidural catheter or if they've had spinal anesthesia, because we can actually cause bleeding into the spinal cord and risk killing the patient. So that's one of the black box warnings that comes with heparin. Oral anticoagulants. Right now we're going to focus on Coumadin. There are some newer ones that the book does not discuss. You can take the time to get to know those on your own if you're curious, but right now we're going to stick to Coumadin, which is the brand name is Coumadin, generic name is warfarin. It was actually discovered from a product of spoiled sweet clover. Cattle that were grazing on the contaminated clover developed hemorrhagic disease. In addition, people who drank the milk from those cows also developed that disease because this medication thinned out their blood and they started bleeding all over the place. Onset is slow, usually takes anywhere from 12 hours to 3 days because it has to clear the clotting factors that are already active in the blood. Similarly, the duration of action is long, 2 to 10 days, even after the drug has been administered and discontinued. So, there's a couple different brand names. We'll mostly focus on Coumadin, however, there's also Jantoven, is another brand name of this medication. Usually once a patient is started on a brand or generic, they stick to the generic or the brand because the reaction between the two can vary wildly. So once we've got them stabilized on something, we don't want to switch them onto another branded generic of the same type. Side effects include nausea, diarrhea, hypotension, fatigue, headache, and alopecia. Hemorrhage is always the most significant problem with these anticoagulants, and we can notice that in blood in stool, blood in the urine, blood in vomit, easy bruising or bleeding of the gums. In severe hemorrhage, we would again we would use vitamin K as an antidote. Vitamin K, so warfarin is essentially a vitamin K inhibition agent. So if we give vitamin K, we're sort of fighting back and overriding that warfarin inhibition. It's available, the antidote is available orally and as an injection. And warfarin does cross the placenta, so a major no-no with warfarin is to give it to pregnant women. It's almost, actually it's never given to pregnant women. Heparin is actually the drug of choice because it does not cross the placenta. Moving on to antiplatelet drugs. Oral antiplatelets include aspirin, dipyridamol, and clopidogrel and ticlopidine. Aspirin alters cyclooxygenase, whereas dipyridamol increases adenosine. So the last two there, clopidogrel and ticlopidine, Inhibit platelet aggregation by blocking adenosine diphosphate binding to membrane receptors and preventing ADP activation of glycoprotein 2A and 3B in the coagulation cascade. That's a mouthful. Just remember that they inhibit platelet aggregation. Dipyridamole, however, is usually combined with aspirin because it's a weak platelet inhibitor. It reversibly interferes with platelet aggregation by, again, increasing adenosine, which is an inhibitor of platelet reactivity. So, side effects for these antiplatelet drugs include headache, vomiting, rash, dizziness, and diarrhea. The last two, ticlopidine and clopidogrel, can also cause low platelet count, so we will keep an eye on those labs. Special considerations. Anticoagulant therapy should be administered at the same time every day. Generally, we observe patients for signs of bleeding and hemorrhage, as well as we get platelet count, so we'll keep an eye on labs. Sometimes these patients will be called in to do labs every 4 to 6 weeks to keep an eye on how effective the medication is. Heparin vials are available in many different strengths, so we always encourage nurses to really take a look at the vial that they're going to use to draw up the medication to make sure that they have the right strength. Anticoagulants of any type are contraindicated in patients with bacterial endocarditis, which is an infection of the heart, ulcerative lesions in their stomach, threatened abortion, again, recent surgery on the brainal spinal cord, and with injectable anticoagulants, indwelling epidural catheters or recent spinal anesthesia. Let's see, moving on to monitoring. We're not going to talk too much about this. When we talk about heparin, they're looking at PTT or PT, prothrombin time, or partial thromboplastin time. When we talk about warfarin, we're looking at INRs, which is international normalized ratio. So, moving into the last part of this chapter, fibrinolytic or thrombolytic drugs are clot busters. They dissolve clots, and they worked on a formed clot, so they're breaking up that clot to sort of open a vessel. This class of drugs includes urokinase, streptokinase, alteplase, and tenecteplase. We're not going to get too deep into it, but we use them in situations like pulmonary clots and coronary artery clots, as well as clots in the carotid artery that are cutting off blood supply to the brain. They're usually administered as soon as possible, anywhere from 1 to 6 hours after the incident, and there are contraindications to using them, such as active internal bleeding, cerebrovascular accident or stroke within the past 2 months, and recent cranial surgery, intracranial tumors, etc. Those medications are kind of a last-ditch effort and a hope for the best. Sometimes when we give them, patients still do pass, but it's our last-ditch effort that we can use to save that patient. There's a comparison of them on slide 20. You can take a look at that. So preferred therapies before we run out of time on this video and have to do a second one. Heparin is approved for the prophylaxis and treatment of DVT, deep vein thrombosis, pulmonary embolism, etc. Standard heparin is always the preferred drug of choice when given to pregnant women. Low molecular weight heparins are used for the prevention of DVT and in selective procedures such as knee replacement and hip replacement. Warfarin is used in the prevention and treatment of venous thrombosis. It's also used in pulmonary embolisms and atrial fibrillation to prevent embolization or re-embolization. Anticoagulant and antiplatelet drugs are also indicated in coronary artery disease to protect from heart attack, stroke, and chest pain. And last but not least, of course, our clot busters are going to be used to break up a clot. We talked a little bit about vitamin K and protamine. The last one we're going to talk about is aminocaproic acid, which inhibits fibrinolysin activation and can actually stop bleeding. It's the exact opposite. The major risk with this is not only do we stop bleeding, but we cause clotting all over the place. Otherwise, side effects for aminocaproic acid include headache, diarrhea, cramps, and rash. So that pretty much covers this chapter. We'll be moving on to chapter 29 shortly.